Hello, and welcome to the Society of Hospital Medicine's Education Consult Series. Today, we're going to talk about learner handoffs with myself, Dan McFarlane of The Ohio State University, Michael Lannetti of Vandalia Health, and Lily Ackerman of Thomas Jefferson University. Welcome, everybody. So my question today for the consult team is, I've been having a lot of difficulty with my learners and being able to identify their strengths in a timely fashion. I feel like by the time I really understand what they're good at and what they need work with, it's the end of our time together, end of our week together, and I just don't have time to really make positive changes for them. I was wondering if you guys had any suggestions for helping me get a jump on that.
Well, this is an excellent question we often encounter. And as educators evaluating trainees are often evaluated by competency-based medical assessments, meaning educators are assessing the trainees to see if they've mastered or attained the ability to perform a certain skill set. So as educators, we're constantly observing learners and providing feedback and evaluations on the learner's skills and abilities. There are several challenges, though, related with these frequent assessments. As we all know, learners are always changing rotations, and as attendings, our schedules don't always line up with the same learners. Some of us may only work with learners for a few days to a week at a time. Because of the asynchronous schedules of learners and educators, feedback can be uncoordinated, leading to missed opportunities to help our learners attain the required skills and abilities they need to become competent physicians. Learner handoffs have been proposed as a solution to address these issues.
So what is the definition of a learner handoff? It's in the literature, sharing of information between a faculty supervisor involved in the education of learners. This includes medical students and residents. It's similar to a patient handoff, but you are actually handing off educational milestones. This occurs throughout educational phases between clinical rotations. It can also occur between undergraduate medical education and graduate medical education, for example, med school and residency programs.
Well, why do we have to have learner handoffs? Well, competency-based medical education demands a continuum in which training and assessments are individualized, continuous, and growth-oriented. Frequently, medical education, though, consists of isolated assessments with limited information shared across educational phases and between clinical educators. The learners do not always get the continuous feedback they need to help them grow, and the feedback learners do get is often isolated and repetitive, not taking into account their needs or prior assessments. And as educators, when we do communicate about learners, it is often informal and unstructured, lacking specific goals or plans for improvements to help the trainees. Like, oh, that intern needs a lot of help.
This sounds like a great idea. Tell me more about the literature behind it.
So unfortunately, this is a relatively new concept. There is not much in the literature, but there is one small survey involving pediatric hospitalists. Although most were familiar with the concept of learner handoffs, there were very, very few who actually received any formal training, did it in a structured format, and only a third reported that it was an expectation. For those who actually did do learner handoffs, it was not too much of a time commitment, on average about 5 minutes. It improved some benefits, just improved ability to give accurate feedback. It helped tailor teaching, and they felt that it improved patient care.
It sounds like it could help me. So what actually should I include in my learner handoff?
Well, learner handoffs can be within a rotation. For example, the attending would change when the attending would change on an inpatient wards team, or between rotations. An example would be if the learner moves on from an inpatient medicine team and goes on to a subspecialty service, or between undergraduate and graduate medical education, when a student graduates and becomes a resident, or a resident goes on to a fellowship program. Additionally, the handoffs can be informal, formal, or structured exchanges.
So, what are the types of learner handoffs you may be wondering? So far, within the medical education realm, they describe three types of handoffs. One is a formal type of handoff that includes rotation evaluations, what's found in a clinical competency committee, where they address knowledge gaps or issues such as professionalism and try to come up with individual learning plans for the students or residents. There also is structured exchanges, which is a handoff between attendings as they move from one rotation to the other. You explain how each team member is performing and overall give you an evaluation or impression. And then there's the informal type of handoff. This is kind of informally in speaking about students or residents in a workspace, and you just talk about learners without a formal structure.
So there are several key practices to having successful learner handoffs. First, there has to be a purpose in the handoff, and that purpose is to improve the learner's skills, abilities, and performance while meeting the learner's needs every day. Next, the learner handoffs have to be designed to promote the growth of the learner and meet the learner's professional goals, taking into account multiple cycle of assessments and feedbacks for the learner. Additionally, we have to allow the learner time to self-reflect and decide if the learner is making progress towards their goals. Additionally, the learner handoffs need to be learner-driven. Learners aren't identical in what areas they need to improve. And individualized learning plans and goals should be created and shared across learner handoffs, taking into account the individualized learner needs, which are constantly changing. Learner handoffs should also be standardized in their format for all learners. Just like with the patient handoffs, a structured approach makes sure no key information about the learner is missed. The handoff should also be transparent. By being transparent to the learners about the handoffs and the goals of the handoffs, there will be less learner anxiety. Furthermore, learner handoffs should have context. As educators, we want to make sure we have the infrastructure and the tools available to help the learners, like a coach available to help a learner develop a differential diagnosis, or a sim room where a resident can practice a central line. We also want to be mindful of the timing of the learner handoff. For example, right before the residency match may not be the appropriate time to do learner handoffs discussing the learner's weaknesses. Additionally, we want to make sure the information conveyed in the learner handoff is only shared with the appropriate individuals who are working to help the learner improve. For example, areas for improvement of a student shouldn't be shared with the residency program director who hasn't worked with the student. Importantly, as humans, we all like to vent, but it is important to remember that the learner handoffs are not venting, but constructive feedback designed to help the learner and our colleagues identify opportunities for the learner to improve in their abilities and skills.
Mike, I really appreciate that. I think it's really great. And I have an opportunity to know kind of where my learner is before I start a rotation. My only fear is there any concern with sort of creating bias with struggling learners? I know that if I came on service and knew that a learner was struggling, I might think about them differently or treat them maybe differently in terms of what they need to learn. Is that a concern at all?
Definitely. I think that is the key issue that's been identified in the literature. There's a concern for bias that can even have consequences, such as fewer career opportunities. For those learners who are identified as struggling in certain areas, mistakes can be magnified. They can be excessively scrutinized during their assessments. Residents and students seen as weaker may be excluded from learning opportunities, such as doing procedures independently or having an opportunity to do independent patient care. Well-being and career trajectory can be compromised, and they can also suffer from fewer opportunities to supervise junior learners.
So some things to consider from the learner's perspective. For the benefits, learners receive individualized, tailored educational experiences and feedback that enable longitudinal growth. There is less time wasted on rediscovering the learner's strengths and weaknesses. We are not constantly reinventing the wheel. And learner handoffs correctly identify the learner's abilities, so the learner is not put in a situation to do a task or skill they cannot safely perform. As far as the concerns, the biggest concern is the potential for biased assessment. One educator says a learner is struggling with a skill, and the next educator may think that that learner is struggling despite the learner improving with that skill. The resulting stigmatization of the learner can lead to performance anxiety. The learner can feel any mistake will constantly follow them.
Things to consider for faculty are that benefits that you can get more efficient and you can direct your teaching and feedback. You have more data points to work with when you consider your decisions on how closely to supervise residents and students and where to focus your teaching. And it also helps that you acknowledge concerns between faculty members. And some common concerns are, again, the risk for bias in your assessments and evaluations. And attention can often be directed to specific weaknesses at the detriment where you're missing other important things that residents and students have strengths in.
Things to consider from a system perspective for the benefits, by passing on what a learner is capable of performing in a learner handoff, the new educator will understand the limitations of the learner's abilities and make sure he is not in a situation to cause patient harm. Furthermore, the new educator or faculty will know when to override the learner if the learner asks to do something they are not capable of doing. Again, this provides patient safety. But the concern comes in when a learner's abilities are misidentified, and this leads to learners performing tasks they are not capable of doing or being deprived of opportunities to do tasks they are able to do. Furthermore, from a system standpoint, learner confidentiality is a concern. Again, could information about a learner be passed on to someone who does not need to know that information? In conclusion, the benefits of learner handoffs are they build on previous assessments and feedback, providing longitudinal observation and growth. The risks of learner handoffs are bias from one educator to another, as well as the confidentiality of the learner. Learner handoffs are helpful in helping faculty avoiding time on rediscovering strengths and weaknesses of learners that have already been discovered. Again, we're not constantly reinventing the wheel. And knowing the learner better enables faculty members to focus on teaching and feedback on learner strengths and weaknesses, particularly when we as clinical educators have limited time to work with the learner. Learner handoffs can improve patient safety by helping to determine the appropriate level of supervision required for learners. Again, learners aren't doing skills alone they are not capable of. And learner handoffs can reduce anxiety surrounding entrustment of competency decisions.
So take-home messages from this are that learner handoffs have been positively received for helping with teaching and feedback. To know that they are usually unstructured, unexpected, and delivered by untrained supervisors. Most institutions really don't have in place a specific methodology. It might be worth developing a learner handoff tool by working with your faculty and those in the education program leadership that can help trainee professional development and can also help with any concerns for added bias. Thank you very
everybody.
much.
This is great. I really am looking forward to going back to my partners and creating a learner handoff.
And these are references.